Hi, I'm Dr. Linda Eckert, and I'm a professor of obstetrics and gynecology at the University of Washington in Seattle. And today we're going to talk about vaccine communication for the obstetrician gynecologist. As we're all aware, we're being asked to give more and more vaccines routinely in our practice, and the goal of these vignettes is to offer some practical points for how to have those conversations with our patients. So the first vignette we're going to have today is why should we actually have this conversation. Today I'm going to focus most on the vaccines that we use most commonly in our office and how to have the conversation around these vaccines, but hopefully also these lessons will apply to other vaccines as we need to use them in our practice. And of course, the most common vaccines that we tend to use in our practice are flu vaccine and Tdap, and I'm going to particularly dwell on their use in maternal immunizations to give to our pregnant mothers. And then HPV vaccine, which is of course indicated for all patients 26 down to the age of 9. Not only will I talk specifically about these vaccines, but I'm also going to talk a bit about following guidelines and how to use the guidelines to help you not only maintain the adequate standard of care in your practice, but also to have conversations with your patients about choosing these vaccines. And lastly, I want to introduce the idea that studies have shown that when we as obstetrician gynecologists approach our pregnant patients with the idea of immunization, that we are allowed, therefore, to have the first touch point or conversation with them about the value of immunizations, not only for their fetus and for them themselves as patients, but for their newborn and toddler and growing child. And that when we do have these conversations and bring this up with our patients, it can help increase vaccine coverage for their infant, toddler, child, and so forth after they quit being our patients but become the pediatric patient. Okay, briefly, I want to review the concept of maternal immunization. So, as we know, when we give moms who are pregnant vaccines, it boosts the maternal level of pathogen-specific antibodies, which increases it in the mom's bloodstream, and then allows her to pass this on through the umbilical cord to the baby and increases the baby's level of these antibodies, so that once the baby is born, then the baby is able to adequately respond to active immunization or infectious challenges. And a graphical representation of that might look like this. The mom has antibodies in her bloodstream. So this is birth, and at birth she has this particular level of antibody that she's going to be able to pass through the umbilical cord to the baby. So then the baby has this level of antibody, and it's not until the baby starts getting their own immunization around 4 months of age, for instance with Tdap, that they really can boost and get their own immune response going. And this area here, where it's called the window of vulnerability, where the maternal antibody has waned, but the infant antibody has not taken off enough to allow protection. And what we do with maternal immunization is we get a big boost of these antibodies in the pregnant women. So now the antibody in the pregnant women is above the threshold level for protection for the infant. And so when birth comes along, we have a lot higher level of antibody in pregnant women. So she passes this on to her baby, and so even as this antibody wanes in the baby and the baby's own takes off, there is an extra level here that came because of this boost. And this extra level now closes this window of vulnerability, and the baby becomes protected. So we do have two patients that we're considering when we're discussing immunization with our pregnant patients. There, of course, is the pregnant mom. And, you know, when we talk about flu vaccine and Tdap vaccine, we are talking about the benefits to the mom, but we're also talking about the benefits to the baby. So what about flu? Well, we definitely know that flu is more dangerous in pregnancy. We know that when women who are pregnant catch the flu, they are much more likely to develop pneumonia, to end up in the hospitalization, to develop respiratory distress. It's pretty dangerous relative to a non-pregnant woman to catch the flu when you're pregnant. So there's definitely the advantage of giving the mom the flu vaccine. But for the baby, there's a huge advantage of giving the baby the flu vaccine. There's now been studies that have shown in multiple continents, in multiple countries, that if you give pregnant women flu vaccine for their babies, it decreases markedly the risk of developing pneumonia, hospitalizations, respiratory illnesses. So not only when we vaccinate the pregnant women are we protecting them themselves, but we're offering a great service for their babies in the first 6 to 12 months of life. And I found when I start making that argument, it goes quite well with patients when they know that getting this vaccine will help protect their baby. Now, as far as Tdap goes, Tdap, we definitely know that we want to give Tdap for the babies because we know the first 3 months of life are when babies die when they get pertussis. And in fact, if you look at all the curves as far as the mortality for pertussis, it's definitely the infants. And the infants catch it from the people around them. So if we can give the mom antibodies and she passes them to her infants, then we can decrease the death rate in the babies from pertussis. But what we also need to talk about with moms is they don't want to catch pertussis either. This is not a fun illness. It may not kill adults. It may not put you in the intensive care unit like flu can, but it's incredibly uncomfortable. And you can cough for 6 weeks, and you can have vomiting from your coughing. You can even break a rib. And in fact, part of my passion for immunization came from caring for a pregnant woman who acquired pertussis when she was 6 months pregnant, broke her rib from coughing when she was 6 months pregnant, went into preterm labor, and had this baby at 32 weeks. And that is one of the reasons why I became so passionate for vaccinating pregnant women. What about conversations around the HPV vaccine? I think the message that has been shown to be the most effective in studies is to talk about cancer, to talk about it as a cancer-saving vaccine. And it's an incredible cancer-saving vaccine. Now with the nanovalent vaccine that's available in our country and is indicated for all from 9 to 26, both male and female, but in our patient population as OBGYNs, we may be hitting the 18 to 26-year-olds, and we should be recommending this for everybody. Why? Well, for one thing, the nanovalent decreases cervical cancer by 92% if you give it to HPV-naive people. 92% is huge. What about the people, though, who've already had an abnormal pap smear or had a LEEP? Again, studies show that the HPV vaccine given to somebody who's already had a LEEP can decrease future dysplasia and future pap smear abnormalities by up to 50%. This is a very significant decrease as well, not only in angst to the patient, but also in cost for the evaluations, colposcopy, etc. And so I think it's very worthwhile to recommend having the HPV vaccine, even if somebody has already had an abnormal pap smear. The second reason as OBGYNs that we can really have these conversations is we are often talking to parents. Parents who have children that are adolescents, both male and female. And it's an important opportunity when they come in for their annual exam or conversations and we're talking to them about vaccines. We can also mention to them, hey, have you gotten your child immunized against the HPV vaccine? And tell them, why this is such a good deal and why they should do it. Now, what about following the rules, following the guidelines? How can this be helpful? First of all, it definitely can help us with our standard of care, making sure that we're following the guidelines that have been set for us by careful review of the literature and careful examination. And secondly, it can help us when we're talking to our patients saying that, hey, we want to be a practice or I want to be a doctor that follows what has been suggested. What about the World Health Organization? Well, globally, the World Health Organization has made a recommendation that all pregnant women all over the globe, when possible, receive a flu vaccine. So this is not just the United States, this is not just industrialized countries, but essentially the World Health Organization has recommended flu vaccine for all pregnant women. The same thing for HPV. The World Health Organization has recommended that all girls, they're focusing mostly on girls at this point, from 9 to 14 years of age, receive the HPV vaccine globally. So I like to tell my patients when I'm recommending the flu vaccine in pregnancy, for instance, that this is a recommendation that's made worldwide. It's not just for you or for people in this country, but the World Health Organization has deemed flu vaccine and pregnancy to be a priority for all pregnant women. Secondly, of course, in our country we have the CDC, and the CDC, is recommending the flu vaccine in pregnancy and also Tdap with every pregnancy. And so I like to tell the patients that, we want to do it every pregnancy, and this is why, and go over that with them, and again following the rules. Of course, there's also the HPV vaccine in our country that's for males and females from the ages of 9 to 26. And then the American College of OB-GYN, of course, agrees with the CDC in the recommendations and backs them up. And lastly, I just want to point out that there is this website, immunizationforwomen.org. That's the American College of OB-GYN website that has a whole plethora of information, not only about guidelines, about the vaccines, who to use them for, about many other vaccines, not just these 3. And this is a very valuable resource that I would encourage you to access and will help you immensely to increase the immunization coverage in your office. Thank you very much.